In this class, we're going to discuss sexual counseling for the ostomy patient. We're going to start with some general concepts. We're going to talk a lot about why ostomy patients may be at risk for sexual dysfunction, and we're going to walk through a pathway for sexual counseling. Now, we have already talked about the impact of ostomy surgery on the patient. We've talked about the fact that they're dealing with multiple threats and multiple losses. There's been a change in the way their body works, and it involves elimination, which is a very sensitive and private subject. It involves a change in the way their body looks. So it's a visible change, visible to them, visible to their partner. That requires a lot of adjustment for both. We'll come back to that. And we've talked about the fact that they have to deal with that loss of sameness, that now they feel different. And that's hard because we don't want to be different in a negative way. We only want to be different in a positive way. And we've talked about the fact that the new ostomy patient is also frequently dealing with issues related to cancer, issues related to inflammatory bowel disease, so they have a lot on their plate. We have talked about critical aspects of rehabilitative care. We've talked about that our goal for that patient is for them to resume their life, to get back into the activities that matter to them, including sexual activity and their sexual relationship. However, we've talked about the importance of continence to that patient before they can move back into their usual activities. And we've talked about our responsibility for helping them to establish a secure pouching system and for teaching them the critical elements of self-care. Once we've done that, then we can work with the patient on issues related to going back to work, resuming recreational activity, and resuming sexual activity. When we look at characteristics of intimate relationships, it's very clear that an ostomy can be a threat because intimate relationships require closeness. They require openness between partners. Being in a sexual relationship makes you vulnerable. All the more critical to trust your partner, to have that open communication with your partner. You have to be able to share private information and private experiences and concerns. So when we talk about sexual rehabilitation and resuming sexual activity, and we talk about sexual counseling, throughout that, we keep coming back to we have to lay the groundwork. We have to establish a relationship with the patient. We have to help that patient establish a secure pouching system. We have to make sure that that patient is comfortable and confident in self-care. We have to encourage the patient and the partner to be open with each other, to share their concerns, to share their feelings as they each adapt to this change. And then they're ready to resume sexual activity. So the things that we can do to support sexual rehabilitation and resumption of sexual activity, we provide support for the patient in walking that path and making those adjustments. We can provide support to the significant other because they must adapt as well, and we'll come back to that. And we're going to talk more about how important it is for both the patient and the partner to separate their feelings about the stoma from their feelings about the person. Why do we as WOC nurses do sexual counseling? Because it's an important concern for our patients. And if you look around, is anyone else doing it? I bet you don't find anyone else doing it. That's what we hear from our patients. 40%, we talked about this earlier, in quality of life studies pretty much across the globe, 40% of the patients said they had sexual concerns that were not addressed. No one talked to them, no one gave them a chance to ask questions, and they left not knowing, when, how, what. I remember right after I got out of ET school, that's what it's called at that point, ET school, WOC nursing program, I read an open letter in the journal from a patient. And this gentleman had undergone cystoprostatectomy for bladder cancer. And his open letter was a plea to ostomy nurses to address sexual issues with their patients. And his point was, he had an operation that had a major impact on sexual function. His physician did not talk to him about this. His nurse did not talk to him about this. His ostomy nurse did not talk to him about this. He said he got home, he knew that he wasn't getting erections anymore. He knew things were different. He didn't know what to do about it. He didn't even know how to really talk to his wife about it. And she didn't know how to talk to him. Neither one of them knew what to do. So he said that his wife didn't want to put any pressure on him, so she started sleeping in another bed so that he wouldn't feel pressured to perform sexually. And then he said over time she started sleeping in a different room. He said, what I miss the most is not the sex. What I miss the most is the closeness, the intimacy. I feel like my relationship with my wife has changed from a sexual relationship to more of a platonic relationship. And I don't really think that had to happen. It's like if somebody had just explained to us what to expect, what could be done, given us some guidelines, even opened the door so we knew how to talk to each other, it would have made all the difference in the world. And he said, I'm writing this letter to you as nurses because I think you're much more likely to step up to the plate and to bring up the discussion, open the discussion, to answer those questions than the physicians. I think we can. We definitely believe we should. And we want to give you the tools that you need and the information you need to be effective in the role of sexual counseling. So what are the tools you need? What's the knowledge that you need? As the faculty, 3 things have been identified. First of all, and we believe you have this, you need an awareness and an appreciation that sexuality is an important aspect of human life and that sexual concerns are valid and should be addressed. And we're pretty confident that you're on board there. We know that ostomy patients frequently express concerns about how their sexual partner will relate to them and whether or not this ostomy is going to interfere with their sexual relationship, interfere with their closeness to their significant other. The second thing we believe you need is a clear understanding as to how specific surgical procedures can impact on sexual function. Now, we don't expect you to know this at baseline, but that's what we're going to be covering in part during this class. We want to make it very clear to you how an abdominal perineal resection might impact on sexual function, how a cystoprostatectomy might impact on sexual function. Our goal is for you to have the information you need to be able to answer your patient's questions. And finally, you need to be comfortable with the subject. And the only way you're going to get comfortable with the subject is just with time and experience. This isn't something we can give to you, but we can tell you it will come if you make yourself bring this up to patients. Give your patients a chance to ask questions, answer their questions. You will become progressively more comfortable in this role. So in this class, we're going to focus on what you need to know, and then we're going to ask you to take the next step. Be the one who brings this up to your patients. Be the one who answers their questions, and you will find that you become progressively more comfortable. I remember when I was a new nurse, and I had a young patient. He was in his 30s, and he was a new spinal cord injury patient. He was a paraplegic. I worked with him and his wife on multiple issues, including bowel function, bladder function. I was not a spinal cord injury expert. I was a staff nurse, so I was doing the best I could with the information I had. And one day he said to me, you know, we have a lot of questions about sex. We don't know what I can do. We don't know how to make it work. We don't know if we can make it work. Nobody's brought this up. And I said, you know, I don't know. I don't have the answers, but I will find somebody who has the answers, and I will make sure they come and talk to me. So I thought I knew just the person because he had a urologist on his case. And I thought, well, the urologist will, of course, know the answers. And this particular urologist never came to the floor without making a sexual comment or innuendo. So I thought, well, he's very tuned in to sexual issues. He should be perfect. Not perfect. I told him what the patient's concerns and questions were, and he becomes very flustered and can't make eye contact. He's looking at the floor, and it's like, well, okay, I'll go talk to him if you come with me. And I'm like, I'm going to come with you. I want to hear what you have to say because I want to be able to answer questions next time around. So we go to the patient's room, and he doesn't do much better in the patient's room than he did at the nurse's station. Finally, he ends up saying something like, well, why don't you go home and give it a try and see what happens. I'm like, well, gosh, I could have said that, and I could have done it much better. Now, I have the knowledge needed to answer that patient's questions. Knowledge is power. Knowledge adds comfort. And that's our goal for you to have the knowledge, because we're pretty confident that if you have the knowledge, we know you have the commitment to your patients, that if you have the knowledge, you will bring it up, you will be able to answer their questions, and in so doing, you will become progressively more comfortable in this role. So don't expect to feel comfortable at first. We're going to teach you some lines you can use to bring it up. Your goal, practice those lines, get good at them, get comfortable with them. That will open the door for you and your patients. So let's talk about the impact of ostomy surgery on sexual function. First of all, we're going to talk about the psychological impact. And you've heard a lot about this, that ostomy surgery changes the way your body works, changes the way your body looks, changes your comfort level with your body. And if you're not comfortable with your body, it is very threatening to be intimate with another person. So you can see that ostomy surgery creates a major psychological hurdle for both men and women. I point out that men are subject to the same psychological issues and concerns as women. Women are much more likely to verbalize these concerns. They're much more likely to say, I'm worried about how my sexual partner is going to react. I don't think he's going to want to have sex with me. A male may not say that as overtly. It does not mean that that male patient does not have sexual concerns. It does not mean that that male patient does not feel vulnerable going home. Also, we have to realize that men are at risk for both organic sexual dysfunction and psychogenic sexual dysfunction. So let's talk about each of those. Psychogenic sexual dysfunction means there's nothing wrong organically. It means that everything works. But I'm so worried about how my partner is going to respond to me, or maybe I'm so worried about the possibility of organic dysfunction that I'm unable to get an erection. The reality is that males who have wide pelvic resections and males who have removal of the prostate gland are at risk for organic sexual dysfunction. So they're at risk for organic sexual dysfunction, plus they're frequently concerned about partner response. That makes them, the combination makes them very high risk for psychogenic dysfunction. It's important to differentiate between psychogenic dysfunction and organic dysfunction because we treat them differently. Psychogenic dysfunction is treated by reassuring the patient that there are no organic issues and by working with the patient and the partner to help them be comfortable with each other and comfortable with moving back into their sexual relationship. That won't work with organic sexual dysfunction. If it's organic, we have to treat with medications, with pump devices, with surgery. So if you have a patient postoperatively who reports inability to get an erection, you need to determine, is this organic or is it psychogenic? An easy way to do that, they have this fairly involved study where they do something called nocturnal penile tumescence monitoring, where the patient goes into a sleep lab and they put this little pressure-sensitive cuff around the penis and hook it up to a computer. So the patient's all wired up, and then they tell them to go to sleep. It amazes me that anyone can sleep under those conditions. But here's the basis for that study. During REM sleep, men get erections. So they want him to go to sleep so they can see if he has a spontaneous erection during REM sleep. So it's like, go to sleep, and in the morning we'll tell you what he did during the night. So that's a very involved study. I think it's fairly costly. There are some very simple questions you can ask that will get at the same information, and there's a much less expensive, although much less scientific study. A very simple question is, do you ever get erections? Do you wake up with morning erections? Most men do. If you wake up with a morning erection, that tells you everything works. Your nerve pathways are intact. You can take that worry off the table and just focus on becoming comfortable with yourself, knowing how to manage your pouch and your stoma, being open with your partner so that you're comfortable resuming sexual activity. In contrast, if you never have morning erections, then we do need to take that next step, either do nocturnal penile tumescence monitoring to verify organic dysfunction or rule it out. But the poor man's approach to nocturnal penile tumescence monitoring is to take a roll of stamps. The stamps have to be connected, and lick the stamps and put a strip around the penile shaft at bedtime. And if erections occur during the night, what will happen is the perforations will tear. And in the morning, you'll see evidence that erections occur during the night. So I always think it must be like waking up to see if the Easter Bunny came or whatever. Bottom line, if a male patient reports inability to get an erection, step number one is to determine, is this psychogenic or is it organic? Ask about morning erections, ask if he gets erections with masturbation, and consider either the stamp test or nocturnal penile tumescence monitoring to determine, is this organic, is it psychogenic? That helps direct treatment. What about women? Women frequently verbalize feelings of sexual unattractiveness. A lot of times women will say, I don't think anybody's going to want to have sex with me. Sometimes even when their partner's sitting right there saying, I'm going to be okay, that doesn't bother me, that's not going to get in my way. And I've had patients say, yes it will, because women think we always know the answers. Even if our partner's saying something, we're like, no, that's what you think, but you're wrong. Why is this important? It's very important for the following reason. If I, the female patient, am convinced that my partner is not going to want to have sex with me, if I'm convinced that he will not find me sexually attractive, even if he's sitting there saying, I still want to have sex with you, I don't care about that pouch, I don't care about that bag, it's important to help me separate my feelings from the feelings of my partner. Because if I feel very unattractive, if I am convinced that he will not find me attractive, how am I going to act when we do resume sexual activity? I'm going to be very withdrawn. I'm not going to be an active sexual partner. And it turns out that sexual arousal for a male is very dependent on the partner's level of arousal. So if he has a very involved, aroused, giving partner, the male becomes more aroused. In contrast, if I'm a stick and not contributing and not participating, then his level of arousal drops and he may lose his erection. And then what do I think? See, I was right. But I wasn't right. So very important, if you hear that from a patient, to say, okay, I hear what you're saying. I hear that you do not believe that your partner will find you attractive. Have you talked to your partner? Well, yeah, I talked to him. And what does he say? Well, he says it won't bother him. Do you have any reason not to believe him? Is he usually honest with you? Well, yeah, he's usually honest with me. Does he usually want to have sex? No, he always wants to have sex. What if you're having a bad hair day? He doesn't care about my hair, right? What if you're mad at each other? Well, he just says, we won't talk. Okay, so what you're telling me is that your partner's not terribly sensitive to your appearance on a given day. That's not what drives his level of interest in sex. He can get past anger and still be interested in sex. And he's telling you that this is not a big issue for him. He still wants to have sex. Do you have any reason not to believe him? Well, no, I guess not, but I don't feel sexy at all. Okay, that's what we need to work on. We need to work on helping you feel sexually attractive so that you don't shut down. So let's kind of leave him out of it. He doesn't sound like he's having issues. Let's find ways to conceal and secure your pouch so that you can focus on your partner and not focus on the stomach. So we're going to come back and talk about that in more detail. Now let's talk about how ostomy surgery can physically impact on sexual function for both men and women, but it's more common with men, so much of our discussion is going to focus on that. It's not the ostomy, it's the pelvic dissection that can affect the nerves that control sexual function. Here are the patients who are at risk. Men undergoing radical rectal resection, like for rectal cancer. Men undergoing radical cystoprostatectomy for bladder cancer. That radical pelvic dissection creates the risk for damage to the nerves that control erection and ejaculation. For some patients, it will be short-term. For some patients, it can be long-term. We're going to talk about both. Now let's talk about normal function, and then we're going to talk about what can go wrong. Normal function in men is dependent on, you have to have intact blood supply because erection is a neurovascular event. You have to have the blood to support vasodilation. You also have to have intact nerve pathways because it's actually nerve pathways that cause the vessels to dilate that result in erection. So you have to have both blood supply and intact nerve pathways. That's why it's called neurovascular. Also dependent on normal hormone levels, not an issue for our patients, and normal psychological state, which can be an issue as we've already discussed. We're worried about patients who have radical pelvic dissection or radical prostatic resection because that can cause loss of erectile and ejaculatory function. So we're going to go through normal erectile function. I'm going to try to show you on the slide some things. So let's talk about at rest. At rest, no erection, blood flow into and out of the penis is exactly the same, okay? 15 cc's in, 15 cc's out. With sexual stimulation, which can be tactile stimulation, or it can be psychological stimulation, thoughts, visual stimulation, anything that causes sexual arousal. That will activate the parasympathetic pathways. The parasympathetic pathways cause the penile arteries and the blood vessels in the erectile tissue to dilate. Once the penile arteries and the capillaries in the erectile tissue dilate, now the amount of blood flowing into the penis is greater than the amount of blood flowing out through the veins. That begins the process of erection. With increasing arousal, you get increasing dilation, increasing blood flow in, stronger and stronger erection. Erection is further supported by something called the vaso-occlusive mechanism. There's a tough fibrous sheath that surrounds the erectile tissue known as the tunica albuginea. You don't have to know that. But as the erectile tissue becomes engorged with blood, then it presses against the tunica albuginea, which compresses the veins draining the penile tissue. With venous compression, you reduce the amount of blood flowing out, which further strengthens the erection. So primary mechanism is dilation of the arterial vessels and capillaries, supported by reduced venous outflow. So if you look at this slide right here, this is the erectile tissue surrounded by the tunica albuginea. And as the erectile tissue fills, it puts pressure against the tunica albuginea and compresses the veins that are draining on the penile tissue. So bottom line, what do you need for normal erection? You need innervations. You've got to have those intact nerve pathways, and you need normal blood flow. What about ejaculatory function? Ejaculatory function is controlled by the sympathetic nervous system. Now, sometimes we talk about point and shoot theory. It makes it a little bit easier to remember what does what. So you think parasympathetic stimulation controls erection, sympathetic stimulation controls ejaculation. An easy way to remember is parasympathetic points, okay? So erection, parasympathetic points. Sympathetic shoots. So point and shoot theory. And you know you have to point before you can shoot, right? Okay. Now let's go through how sympathetic stimulation controls ejaculatory function. And again, I'm going to try to show you on this slide. With sympathetic stimulation, you get contraction of the prostate gland. When the prostate gland contracts, it propels, so here's the prostate gland. When the prostate gland contracts, it propels seminal fluid into the urethra. And remember that the seminal vesicles empty into the prostate gland. So semen, seminal fluid, is a combination of sperm from the seminal vesicles and prostatic secretions, all mixed together. So when the prostate gland contracts, it propels that seminal fluid into the urethra. That is known as emission. Then, with orgasm, you get contraction of the muscle fibers along the urethra, within the urethral wall. And when the muscle fibers in the urethra contract, it propels the seminal fluid distally. So with orgasm, you get ejaculation. So the role of the sympathetic nervous system is to actually move seminal fluid from the prostate gland into the urethra. And then the seminal fluid actually comes out of the distal penis with orgasm, and that's related to the muscle contractions that propel the seminal fluid along. What about sensation? What about orgasm? For a male, it's very hard for them to imagine that sensation is controlled by a different pathway than erection, and that orgasm is controlled by a different pathway than ejaculation. But in fact, that's the case. So sensation and orgasm are controlled by the pudendal nerve. The pudendal nerve is not an autonomic nerve. It is a sensory motor nerve. So pleasurable sensation related to sexual activity, sexual arousal, is mediated by the sensory fibers in the pudendal nerve, and orgasm is mediated by the motor fibers, which cause muscle contraction that we perceive as orgasm. Now I want to talk about the nerve pathways. This is very important to understand, so you want to spend some time on this content. If you are very clear about the normal nerve pathways, it's going to make a lot more sense to you why certain patients are at risk for dysfunction. So we're going to talk about the pathway followed by the parasympathetic nerves, pathway followed by sympathetic nerves, and pathway followed by pudendal nerves. We will move from that into potential for nerve disruption and for sexual dysfunction. Remember that the parasympathetic and the sympathetic nerves are autonomic nerves. All autonomic nerves originate at the spinal cord and terminate in the target organ. So the nerves that control erection, the parasympathetic nerves, start at the spinal cord, and where are they going to terminate? They're going to cause erection. They cause dilatation of the penile arteries and the erectile tissue, the vessels in the erectile tissue. So that means they have to go from the spinal cord, their point of origin, to the penis, the target organ. Now the pathway they follow, you see it on the slide, and I'm going to try to show it to you as well. They exit the cord at S2 to S4, and I can't tell how well the different colors show up on this slide that you're looking at. But if you look at the slide on top, the parasympathetic nerves are illustrated in yellow. They come off the cord very low, sacral level, S2 to S4. So you think they exit the cord at the base. And then where do they have to go? They have to go to the soft tissue of the penis. Now, if you visualize yourself standing at the very back of the pelvis and think, I need to get from the back of the pelvis, I'm standing behind the rectum. I've just come off the spinal cord. I'm standing behind the rectum, and I have to get over to the penis. What structures lie between the spinal cord and the penis? And the answer is the rectum and then the prostate gland, okay? So here's the rectum, here's the bladder, prostate gland, penis. If you follow the path these little nerve pathways have to follow, they have to come around the rectum, not through the rectum. Around the rectum, they actually divide in one pathway because they're paired nerves. One nerve goes on this side, one nerve goes on the other side. So they're coming around the rectum, through the prostate gland, into the soft tissue of the penis. And if you look at the slide on top, you're looking at the yellow pathways. Again, start at the spinal cord, come around the rectum, through the prostate, into the erectile tissue. They go through the prostatic capsule into the erectile tissue. What do? Once they reach their target organ, they cause the penile arteries to dilate, they cause the capillaries in the erectile tissue to dilate. Critical to erection. What about the sympathetic pathways? Sympathetic pathways, also autonomic nerves. These are the pathways that cause ejaculation. So they are going to start at the spinal cord, and what is their target organ? What's their end point? And their end point is the prostate gland, because they're going to cause contraction of the prostate gland to propel fluid into the urethra. Now, the sympathetic nerves are shown in white here on this slide. And you see, I hope you can see, that the sympathetic nerves exit the cord at a higher point. They exit the cord at the thoracolumbar level, T10 to L2. And they first pass into the abdominal cavity right at the bifurcation of the aorta. And then they drop into the pelvis behind the rectum. And from that point, they follow exactly the same path as the parasympathetics. So they're going to come around the rectum and into the prostate gland. And sometimes when I'm explaining this to patients, and this might help you as well, I remind them of the close proximity between the rectum and the prostate gland. I ask them, when your doctor wants to check your prostate, how does he do it? Well, he puts his finger in the rectum. Why? Because the rectum is right up against the prostate gland. So if these nerves have to get to the prostate gland, they've got to go right around the rectum into the prostate. So around the rectum, okay, into the prostate gland to mediate ejaculation. What's the end result of sympathetic stimulation? Prostate contraction, propulsion of fluid into the urethra, also known as emission. The pudendal nerve follows a very different pathway. It's a sensory motor nerve, not an autonomic nerve. It does come off the cord at S2 to S4, but it does not go through the pelvis. Instead, what it does is it travels to the pelvic floor to innervate the soft tissues and the muscles of the pelvic floor. So the good news is that even in a patient who requires wide rectal dissection or wide prostatic resection, you don't get damage to the pudendal nerve, so those patients will retain sensation and the potential for orgasm even if they lose erectile function or ejaculatory function. Okay, so we've gone through normal, we've gone through pathways. Now let's talk about what are the specific implications for our patients. And if you're following along on your online materials or your hard copy, you should have a box in your materials that says implications for ostomy patients. That's what we're focusing on right now. So we're going to start out with a male patient who is undergoing a narrow rectal resection, narrow APR. Remember, APR stands for abdominal perineal resection of the rectum. So this individual, let's say he's 28 years old, he's had Crohn's disease for 10 years, and he requires removal of the colon and the rectum and a permanent ileostomy. So they're going to take out his rectum. Now, I'm hoping that you can see this little diagram here on the board. I think you can see this diagram. Okay, if you can see this diagram on the board, if not, you'll be able to see it when you come for class, but hopefully you can see it here. I want you to think of this as the little nerve pathways passing through the perirectal tissue. Now, these nerve pathways follow or pass very close to the rectum, but remember they don't go through the rectum and they're not attached to the rectum. They're in the perirectal tissue. That's important because in this patient who's undergoing resection for benign disease, non-malignant disease, they're going to take out the rectum, but they're not going to remove the surrounding tissue. There's no need to remove the surrounding tissue. It's not involved in the disease process. That means that these nerves might be a little bit bruised and might be a little bit swollen just from manipulation in the area, but there's very, very minimal risk of any long-term damage. So what we would tell this patient is When they take out your rectum, they're going to be working right in the area where the nerves that control sexual function are located. So they happen to pass right through the perirectal tissue on their way to the penis and the prostate gland. When your surgeon takes out the rectum, of course, there's going to be a little bit of swelling and bruising in that area from the surgery. And that bruising and swelling could possibly cause some short-term problems getting an erection or ejaculating. There is absolutely minimal risk of any long-term damage because we're not taking out any surrounding tissue. Having said that, I will always point the patient back to the surgeon. I will always say to the patient, I'm going to encourage you to go back to your doctor and talk about this a little bit more. Ask him or her specifically because they can give you very specific information, whereas I'm giving you general information. Now, in our setting, we had a surgeon who did a great job keeping records, and we could actually tell his patients, Dr. So-and-so has been keeping records for 20 years, and he has not had a single patient with long-term issues. So you don't have to worry about that. He's going to be very careful. And even if you have short-term problems, I want you to know they're short-term from bruising and swelling. That's going to resolve within a few weeks, a couple of months at the longest. Now, I want to change the scenario, and I want to talk about a patient who has rectal cancer and who requires wide resection. So when we talk wide and narrow resection, we're talking about how much tissue has to be removed. And in a wide resection, your goal is to assure clear margins. So you are going to take the section of the rectum with the tumor. You're going to take above, below, and all around, because we know that cancer cells migrate. So it's not enough to just take the rectum. In this case, they're going to take the rectum and they're going to take some surrounding tissue. I didn't mean to knock out all the nerves. But it's very likely that some of those nerves will be damaged. If the patient has a very large tumor, if the tumor extends through the rectal wall, that's going to change the amount of tissue that has to be resected, and that's going to increase the risk. Some patients may be a little bit higher risk just because their nerve pathways happen to run closer to the rectum than another patient. So what I have to tell a patient who is undergoing a wide resection for rectal cancer is there's a probability. Let me back up and say how I would say this. I would first explain to the patient, I want to talk to you about the potential for sexual complications after the surgery. And the reason I'm bringing this up is because the nerve pathways that control erection and the nerve pathways that control ejaculation pass right around the rectum. They start at the spinal cord, they go around the rectum, through the prostate, to the penis. When your surgeon goes in there tomorrow, his or her first goal is to get all of the cancer, if at all possible. That means that he has to take the rectum itself and he has to take some of the surrounding tissue, because the surrounding tissue will have some cancer cells. So he's going to have to take some of the tissue around the rectum. That's exactly where those nerves are located, is in the tissue around the rectum. What we know from experience is that most patients who have this operation have at least short-term problems with erection and ejaculation. Because even if those nerves don't get damaged, they typically get bruised and swollen. So I want you to expect to have short-term problems. I don't want you to worry if you don't wake up with a morning erection. That's very common after this operation. Now, depending on how much tissue they have to remove, there's the possibility that those nerves could be damaged and it could be long-term. Hopefully that won't happen. The most common scenario is short-term problems that clear up. But there is the possibility that it could be long-term if your surgeon has to remove a lot of tissue. Again, I'm going to encourage you to talk to your surgeon because he or she knows exactly what they're planning to do and they can give you more specific information. I'm giving you general information. Sorry, I forgot to switch the slide. So again here, if you have a large rectal tumor, let's say that it actually penetrates the rectal wall, so you're taking out the rectum and you're taking out more of the surrounding tissue. If the nerve pathways run right along the rectum, you can see that the more tissue you have to remove, the greater the risk of dysfunction. So let me summarize. Narrow resection for benign disease, Crohn's, ulcerative colitis. The surgeon will be removing the rectum itself, no surrounding tissue. There is a slight risk of temporary dysfunction due to swelling and bruising. There is very, very minimal likelihood of long-term dysfunction. In contrast, for the patient who requires wide rectal resection for rectal cancer, then they have to take the rectum and they have to take surrounding tissue to give the very best chance of cure. Because the nerve pathways pass through the perirectal tissue, there's very high probability of short-term issues. Difficulty getting an erection, difficulty with ejaculation due to trauma and swelling. There is a possibility of long-term dysfunction if the patient has a big tumor, if they have to resect a lot of tissue. In that case, there's the risk of nerve damage and long-term dysfunction. We're going to come back to how we present this to the patient, but basically the pathway is you bring it up, you explain that the reason you brought this up was because the nerves that control erection and ejaculation pass around the rectum on their way to the prostate gland and the penis. That during surgery, it's pretty common for those nerves to get bruised and swollen, and that can cause short-term problems. For the patient with rectal cancer, the additional point you make is the surgeon tomorrow or whatever day you have surgery, his or her first goal is to get all of the cancer if at all possible. That means that he or she will remove the rectum and some of the tissue around the rectum. There's the possibility that the nerves could be seriously damaged and that this could be a long-term problem. If that should occur, treatment is available. When I said risk factors on this slide, the risk factors would be size of the tumor, whether or not the tumor extends through the rectal wall. Also, what if you have a patient who at baseline is already having problems with sexual function? Maybe they're having to take an oral medication to be able to get an erection. Okay, then they're going to be higher risk for problems post-op. Now let's talk about the patient with bladder cancer who requires a cystoprostatectomy. Now, for many years, when they did a cystoprostatectomy, they took out the bladder, they took out the prostate gland, period. Remember that both the parasympathetic and the sympathetic nerves run through the prostate gland. So If they do a straight cystoprostatectomy, the patient will lose both erection and ejaculation. They'll lose ejaculation because the prostate gland has been removed and the prostate is the source of seminal fluid. They'll lose erection because the parasympathetic nerves run through the prostate gland on the way to the erectile tissue. It is very rare for a patient to have a standard cystoprostatectomy. Today, most patients have a nerve-sparing cystoprostatectomy. When they do a nerve-sparing procedure, they take out the bladder, they take out the prostate gland, but they preserve the nerve pathways running through the prostate gland. And the whole point of preserving the nerve pathways that pass through the prostate gland is to preserve erectile function. So if you look at your handout on a nerve-sparing radical cystoprostatectomy, what would you be telling this patient? You would have to explain that they would lose ejaculation because the prostate gland is removed and the prostate gland is the source for the seminal fluid. So nerve-sparing, non-nerve sparing. All patients who undergo cystoprostatectomy lose ejaculatory function. For a younger patient who's interested in having children in the future, we tell them, bank your sperm. Okay. Sensation, potential for orgasm will be retained. And erection is the big question mark. Ejaculation's lost. Sensations retained. Erection, I don't know. So the goal in doing a nerve-sparing procedure is to preserve erectile function. Basically, in doing a nerve-sparing cystoprostatectomy, if you think of my arm as the nerve pathway that's going through the prostate gland into the penis, they're going to scrape the prostatic tissue off of that nerve. And so that nerve is going to sustain a lot of trauma. It's going to be bruised, it's going to be swollen. That means that the patient will lose erection short term. But as that nerve recovers, as the swelling subsides, as the bruising resolves, most patients regain erectile function. That's what you see on the slide. Erectile function in a nerve-sparing cystoprostatectomy. Whole goal, preserve erectile function. That's why we're doing nerve-sparing. So we tell the patient, long term, we expect you to regain erectile function. Short term, we expect you to lose it because that nerve is going to be very bruised and swollen, and it's going to take it months to recover. Typically about 6 months, sometimes even longer. Now, in a number of settings, they're encouraging patients to use pump therapy or penile injections to stimulate erections in the interim. Partly to restore sexual function and the ability to have sex in the interim, but also because think about the fact that erectile tissue is like a vascular sponge. And if that patient does not have an erection for a prolonged period of time, you can get atrophy of the erectile tissue. So depending on what setting you're in, you might see more and more attention to sexual rehabilitation. You might see the urologist counseling patients about using medications and pumps to maintain erectile function until spontaneous erections return. Now, I want you to know you will have a chance to ask questions about all of this content when you're on site for Bridge Week. But if you have questions, if this is not making sense to you, you can also call one of the faculty to talk it through with them so that you're clear. This is critical content. You are not going to be able to explain what to expect to patients if this doesn't make sense to you. That's why we go very carefully through the pathways and then what can happen. So if it's not clear, call a faculty member. Let's talk about female sexual dysfunction. We know less about female sexual dysfunction, partly because there haven't been as many research studies, but also because most females who have rectal cancer are postmenopausal, and so they already have changes in sexual function. And then if they require radiation therapy destroys the vaginal glands that control lubrication, which further obscures the picture. But here's what you need to know. You need to know that vaginal lubrication and clitoral vasocongestion in the female are analogous to erection in the male. So they're going to be controlled by the parasympathetic nerve pathways. And just as the parasympathetic nerves in the male come off the cord, go around the rectum, and then to the penis, in the female, the parasympathetic nerves come off the cord, go around the rectum, and then pass to the vaginal glands and the clitoris. Sensation and orgasm in the female, just as in the male, mediated by the pudendal nerve, so not affected. So what's the impact of radical pelvic dissection? If you come down to narrow rectal resection, so if you're talking to a young woman who's undergoing narrow rectal resection, or a middle-aged woman, sorry, I shouldn't have made it just young. So let's say you're talking to a patient, a female patient, with ulcerative colitis or Crohn's disease who is having her rectum removed. Narrow rectal resection. What would you tell her? You would tell her the nerves that control lubrication and clitoral congestion pass right around the rectum. So there's the possibility that following surgery, you may have a short period of time, weeks to a couple of months, when you have trouble with lubrication. And you should plan to use additional lubricant post-operatively until you find you don't need it. What about wide rectal resection? For wide rectal resection, again, you're taking part of the perirectal tissue. You're much more likely to cause nerve damage. So when talking to a woman with rectal cancer who's undergoing an abdominal perineal resection, I would tell her the nerves that control vaginal lubrication, clitoral congestion, pass right around the rectum. They're very, very likely to be bruised and swollen as a result of the surgery. So most women have problems with lubrication during the first few months after surgery. Also, there's the possibility that those nerves will be damaged. It depends on how much tissue has to be removed. If the nerves are damaged, you may end up needing lubrication long term. Now here's the other thing that we have to be aware of: whether the woman has a narrow rectal resection or a wide rectal resection. Go back to normal female anatomy. So here's the bladder and urethra, here's the vagina, here's the rectum and anal canal. So of course we know that the rectum actually provides support for the vagina. And if we remove the rectum, that is going to change the angle of the vaginal bulge. And that increases the risk for pain during intercourse. There's actually two potential reasons for pain during intercourse. One is that the vagina has tipped backwards because the rectum's no longer there, and the patient and partner might need to change positions. Woman on top might be much more comfortable than woman on bottom. That might eliminate a lot of the discomfort. The other thing that can happen, some women get a lot of scar tissue that forms following removal of the rectum, and that can actually put traction on the vaginal wall that increases pain. Bottom line for us, we should always be doing follow-up with our patients. In the outpatient clinic, we should ask them how they're doing physically, how they're doing psychologically, emotionally, we should ask them, have you resumed sexual activity? Are you having any problems? You might want to specifically ask your female patients, are you having any pain? If that pain is not resolved with lubrication and change in position, then that patient needs to be evaluated by a surgeon. Sometimes they have to revise the scar tissue. What about women with cervical cancer who require radical pelvic surgery, including partial or total vaginectomy? So what you need to know is if you have a patient with extensive cervical cancer or recurrent cervical cancer, when they take them to surgery, you just think where the cervix sits, at the top of the vagina, right behind the bladder, right in front of the rectum. It's literally at the crossroads of the female pelvis, and it can spread in any direction. So when they go to do surgery, many times they have to take out the top third of the vagina because of the location of the cervix and the need to take any involved tissue and to establish clear margins. So most women who have surgery for cervical cancer have at least a partial vaginectomy. As you see on your handout, that's removal of the proximal 1/3 of the vagina. This patient will be able to resume intercourse, but not until the suture line is very well healed. And some of these women have had prior radiation, so we have to tell them, do not resume intercourse until you get clearance from your physician. So let's say that this patient's had the proximal 1/3 of the vagina removed. You can see that the vaginal vault then will be much, much shorter. That's going to have major implications for resumption of sexual activity. So I'm going to need to tell her, do not resume intercourse until cleared by your physician. And when you resume intercourse, you've got to use different positions. You're going to have to experiment a little bit. Woman on top is usually better, side to side is frequently better. Male dominant is rarely acceptable. So she and her partner are going to need to experiment. What about total vaginectomy? If there's extensive vaginal involvement, the patient may lose the entire vagina. Typically, they'll do vaginal reconstruction at the time of the original surgery. Now, they used to wait for a year, thinking, well, we'll let the patient get over this initial surgery and then we'll bring her back for reconstruction. But when you look at a female who has radical pelvic surgery for cervical cancer, these are women undergoing pelvic exenerations, where they have the rectum removed and they have a colostomy, they have the bladder removed and they have a urinary diversion, and then they have the vagina removed. What an attack on your body image. So if they can do reconstruction, that supports psychosexual rehabilitation. Here's the other big thing. If you take out all the pelvic organs, so let's say you have extensive cervical cancer, extensive pelvic involvement. So you take out the bladder and the urethra. You take out the uterus and vagina. You take out the rectum and anal canal. There is nothing in the pelvic cavity. And then what happens? Loops of bowel drop down into that empty pelvis. They tend to stick to the floor of the pelvis. Patients have ended up with fistulas between the bowel and the perineum. They've ended up with small bowel obstructions, all kinds of complications because of failure to partition the abdominal cavity and the pelvic cavity. So reconstruction now is typically done at the time of surgery. They need to find some way to separate abdominal cavity, pelvic cavity. Sometimes they'll do an omental flap to separate the two, but reconstruction of the vagina helps as well. Sometimes they'll use the sigmoid colon to reconstruct the vagina because it's adjacent, and it actually makes a pretty satisfactory neovagina because it's muscle, it's soft, and and there are mucus secreting glands to keep it moist. Sometimes they'll use the gracilis muscles from the inner thigh to create a pocket. That's a much more extensive procedure, but it usually provides a satisfactory outcome long term. They used to use the labia, which was, I can't believe anybody thought that was a good idea, because then you ended up with yet another insult to your body image because you look different externally. Also, intercourse becomes more painful because the labia actually provide a cushioning effect. Probably the worst thing was that people ended up with a dry, hairy vagina, which was not very satisfactory to them or their partner. So that's rarely done anymore. It's almost always either a section of bowel or the gracilis muscles from the inner thigh. And depending on what procedure is done, the patient may need to use a dilator short term. If you are working with these patients, you'll talk with the surgeons, you'll know exactly what it is they do. You might want to go and watch one of the procedures, and then you'll know more about how to counsel patients. Now, we're moving into the specifics of counseling, and we want to remember that it's not just the patient who has to adjust to these changes in body image and body function. The partner has to adjust as well. Any body-altering surgery is a challenge both for the involved person and for their sexual partner. So if your partner had to have an amputation, would that require adaptation on your part? Yes. If your partner had an ostomy, would that require some adaptation, some adjustment on your part? Yes. So we want to provide support for the patient and for the partner. There's really two powerful messages we want to share with the patient and his or her partner. One is that how you feel about the stoma and how you feel about the person are two totally separate things. Remember, the stoma is a substitute for the original anus. And the anus was never designed for cosmetic appeal. Nobody gets picked as a partner because they had the best looking anus around. So even if your partner thinks your stoma is weird looking or ugly, doesn't necessarily change how he or she feels about you. So very helpful to say to the patient and to the partner, no matter how you feel about the stoma, that's different than how you feel about the person. So don't get them mixed up. And secondly, we want to encourage honesty. If I can say honestly, ooh, yeah, that is kind of weird looking, we'll just keep it covered up during sex, that's one thing. If I try to act like it doesn't bother me, you're going to know. And now we have a barrier to overcome. So I have to tell you a cute story that illustrates this very well. I had a woman who was, I think, in her 40s or 50s, I can't remember exactly. And she had had an ostomy, and I went to do her teaching one day. And so she's like, so Dorothy, what are you doing at 2 o'clock today? And I'm like, well, I have some things on my list, but my schedule's flexible, so why do you ask? And she said, well, this is going to sound weird because I've been married for all these years, 20-something years, but my husband wants to look at this thing, and I'm really, really nervous. And, well, I was wondering if you might want to attend the viewing. And I was like, well, will there be refreshments? And she's like, well, I could see what the nurses could find in the nutrient refrigerator. I'm like, never mind, I'll pass on the refreshments and I will attend the viewing. So I get there and we talk a little bit about the fact that they both have to adjust and that it's very common to have negative feelings about the stoma, that a lot of people think they look weird or ugly or whatever, but that doesn't typically change anything about feelings for the individual, for the person. And we also talked about, you know what, it's really good that you said out loud you wanted to see how it looked. That's part of you adjusting, and it's important to be honest. It's better to be honest and say, ugh, that's gross. Let's think how we're going to deal with it than to try to act like you're okay. So I'm like, are you ready? And he's like, I'm ready. And she's like, I'm as ready as I'll get. So we take off the pouch, and he looks at it, and he's like, you know, honey, you're right. That is one weird looking little thing. But I tell you what, he's weird, but you're wonderful. All I want is for you to be okay. We'll get through this, and when we get ready to have a good time, we'll just cover that up. And she was fine. Very helpful just to be open, encourage them to be open, help them separate their feelings about the stoma, their response to the stoma, from their feelings about the person. Okay, so the last 15 minutes or so, I want to just go through a pathway for sexual counseling. We've already talked about common concerns from the ostomy patient related to sexuality. Is anybody going to want to have sex with me? Specifically, is my partner going to want to have sex with me? Is he or she going to still find me sexually attractive? Or are they going to be turned off? And when we get ready to have sex, what do I do? How do I manage this? What do I do at the back? And those are things that we have the answers to. If you have patients who are single, they have another whole set of concerns, and we'll come to that in just a minute. So what are our goals? If the patient's in a sexual relationship already, in a committed relationship, we want to help that patient and their partner maintain a positive relationship. If the patient's single, not in a relationship, sometimes they feel like, well, I guess that does it for me in terms of finding somebody. And you want them to know, you know what, that's really not true. You still have the potential to establish a positive relationship, and we can help you with that. And you definitely want to answer any questions. And I've had women who are like, well, right now I'm divorced, but I'm looking and I've got questions, so you sit down and you give me the answers. It's like, okay, that's what I'm here for. Now, what assessment do you need to do before you start down this path? Well, you definitely want to know what issues and concerns the patient and the partner bring to the table, because number one goal is to answer their questions and address their concerns. I also want to know, is the patient having any problems at baseline? Is this female already having problems with lubrication? Is this male already taking medications to be able to get an erection? Because if they're already having problems with erectile dysfunction, with loss of lubrication, then they're much higher risk for major problems post-op. Doesn't mean we can't get past those problems, just means that it alters my expectations as to what might happen post-op. And again, looking at risk factors for dysfunction. So if I have a male patient who's having a wide resection for rectal cancer, and he has a history of coronary artery disease, and he's diabetic, and he's on hypertensive medications, I know he already has a number of risk factors for poor blood flow to the pelvis and for possible medication interference with erectile function. So again, I want to ask him about any issues at baseline. Okay, the model we're going to use, the pathway we're going to use for sexual counseling is a very widely known, widely used pathway known as the PLICIT model. And it's an acronym. There's 4 levels. Level 1 is permission. Level 2 is limited information. Level 3 is specific suggestions. And level 4 is intensive therapy. And as ostomy nurses, we should be able to provide permission, limited information, and specific suggestions. So let's talk about each one. Permission. Every older teen and cognitively intact adult should get permission. And you give permission by bringing up the subject. If you bring up the subject, it tells that person, hey, this is a valid topic, and I can ask my questions. I've had nurses tell me, well, I didn't bring it up, but he didn't bring it up either, so I figured he didn't have any questions. Well, most of the time, patients are very reluctant to bring this up on their own. They expect us to bring it up if it's an okay topic, and if we do not bring it up, they frequently feel that for some reason it's a taboo subject and they shouldn't bring it up either. So you give permission by bringing it up. I want to give you 2 good lines that you can use to bring up the topic. If you're dealing with a patient who is scheduled for a procedure that is likely to cause disruption in sexual function, you need to bring it up pre-operatively as part of informed consent. And the best way to do that is to say, has your doctor talked with you about the effect this surgery might have on your sexual function, on your ability to have sex? If you have a patient and they're having an ostomy, but the procedure they're having poses no risk for sexual dysfunction, it's not essential to bring it up preoperatively. You can wait and bring it up postoperatively. Whenever you bring it up, a great approach is to say, one question or one concern that most patients have following ostomy surgery is about the impact on their sexual relationship and how to go about having sex with an ostomy. I wanted to see what questions you had. Again, what am I saying to the patient? This is a common concern. Most people have questions. I just need to know what your questions are. Who gets permission? Older teens, cognitively intact adults. Even if you think that patient's no longer having sex, because you know what? You don't know. I remember one day I had 2 patients to pre-op back to back. The first one was a gentleman in his 60s who was having a wide AP resection for rectal cancer. When I brought up the topic, when I asked him, had his surgeon already talked to him about how this surgery might affect his ability to have sex, he's like, oh, I'm not worried about that. We've retired for that. So I said, okay, but I'm still going to give you the basic information because, you know what, you might decide that retirement's not so much fun after all. You might decide to resume sexual activity and you have a right to know. So the second patient that I had to pre-op was in his late 70s. He was going to have a nerve-sparing cystoprostatectomy for bladder cancer. When I walked in, the first thing I noticed was that he had chronic lung disease. He was in the classic chronic lung position, and you could hear it breathe. The second thing I quickly realized he was hard of hearing. And the third thing I realized was he didn't know anything about his surgery, because when I said to him, I told him who I was, I asked him if he had talked to his doctor about the surgery, and he said yes. I said, and what did your doctor tell you? He said, I have cancer in my bladder. I'm like, okay. And he said somebody would come talk to me. Okay, that's me. So I'm going through the whole surgery. It's taking a long time because I have to keep going back and forth to be sure he's understanding because of his hearing loss. I feel like I'm pre-oping half the floor. So you know how you have a conversation with yourself while you're still dialoguing with the patient. So I'm talking to the patient about the surgery and I'm saying to myself, so are you going to bring up sex? I'm like, no, I don't think so. And then I say to myself, you know you're supposed to bring it up. I'm like, give me a break, he can't breathe. And myself is like, you're still supposed to bring it up. I'm like, okay, I'll bring it up. So I get through the basics and then I say to him, has your doctor said anything about how this surgery might affect your ability to have sex? Well, his cognition improves. I swear his hearing improved. He's like, no, he didn't say anything. Why are you saying that? What's going to happen? Tell me, I need to know. Turns out he's definitely sexually active. He knows how to use his oxygen wisely, and he had major concerns. So it was a take-home message to me. You don't know who is still sexually active, so you have to assume they're sexually active and they deserve the information. Okay, the next level is limited information. This means informed consent. This means that any patient who is an older adult, an older teen or an adult who is undergoing a procedure that might alter sexual function has a right to know that preoperatively. Critical component of informed consent. So, limited information is an explanation to the patient about the potential impact of a surgical procedure on sexual function. Now let's say you say to the patient, has your surgeon already talked with you about how this operation might affect your ability to have sex? And the patient's like, no, he didn't say anything. What are you talking about? Number one, I cannot assume that the surgeon really did not say anything. Remember, much of this discussion occurred when the patient might have been in total shock and might have been unable to process. So I'm giving you a roadmap to use in this situation. It's on your online and hard copy materials. What we say in that situation is, I'm going to give you some general information. I'm going to explain to you why I brought this up. I'm going to give you general information about how this surgery, this type of surgery, might impact on sexual function. But only your surgeon can give you specific information because he or she knows exactly what it is they plan to do. So I'm going to give you general information, and then I want you to talk to your surgeon about any specific questions you have. Then I'm going to say the reason I brought this up is that the nerves that control erection and ejaculation pass right around the rectum and go through the prostate gland. That means that when you have your surgery, they're going to be working right in that area. The area where they're doing the surgery is the very same area where these nerve pathways are located. When they do the surgery, there's the possibility that those nerves can be bruised or swollen. And if they become bruised or swollen, then that means they don't work well until that bruising goes away and the swelling goes down, which typically takes several weeks to several months. Now, if they're doing this procedure for cancer, I would move ahead and explain that depending on how much tissue has to be removed, there's the potential for long-term problems, but that treatment is available should that occur. If the patient's having a radical cystoprostatectomy, let's say it's a nerve-sparing cystoprostatectomy, I would explain when they remove your bladder, they're also going to remove your prostate because it's wrapped around the base of the bladder. And so to give you the best chance of cure, they're going to remove the bladder and the prostate. When they remove the prostate, you lose the ability to ejaculate because that's where the seminal fluid comes from. If you still want to have children, that means you need to bank your sperm before surgery. Most of these patients are older. Most of the time they say, I'm not worried about having kids. I'm like, okay, so let's move ahead. You're going to lose ejaculatory function. You won't be able to ejaculate. What about erection? Will you be able to get an erection? Your surgeon's going to do what we call a nerve-sparing procedure, meaning he's going to take out the prostatic tissue, but he's going to leave the nerve that controls erection. The problem is that that nerve's going to be very bruised, very swollen. as a result of the surgery. And it's going to take a number of months for that nerve to recover, typically about 6 months. And we can't guarantee that you'll get erection back. We totally expect that you will. That's why your surgeon's doing this. But we know it's going to take time. And there are no guarantees. Now, I've given you the general information. I'm happy to answer any questions you have, but again, I want you to ask any specific questions. I want you to ask your surgeon. So summarizing the 3 patients that you're likely to be talking to: patient with inflammatory bowel disease necessitating removal of the rectum. I'm going to explain short-term problems with erection and ejaculation are possible. Long-term is extremely, extremely, extremely unlikely because they're only removing the rectum itself, no surrounding tissue. Patient with rectal cancer undergoing wide rectal resection. I'm going to explain short-term problems with erection and ejaculation are very, very common because in removing the rectum and the surrounding tissue, those nerves are typically bruised and swollen. Also, you should know that there's the possibility of long-term problems with erection and ejaculation depending on how much tissue has to be removed. If that occurs, treatment is available. For the patient undergoing nerve-sparing cystoprostatectomy, when they take out your bladder, they're also going to remove the prostate gland. That means you're going to lose the ability to ejaculate. You'll retain sensation. It will still feel good. You'll still be capable of sexual arousal. You'll still be capable of orgasm, but you won't ejaculate. It will be what we call a dry orgasm. What about erection? Your surgeon's going to remove the prostate gland, but he's going to leave the nerve pathways that control erection. That means he's going to literally be scraping the prostatic tissue off of the nerve pathway. So that nerve's going to be very bruised and very swollen, and it's going to take it months to recover. So we do expect you to regain erectile function. There are never guarantees, but we totally expect you to regain erectile function. We will talk to you after surgery about options for getting an erection in the meantime. What questions do you have? I can answer general questions. Your surgeon will answer specific questions. Okay, the third category is specific suggestions, and we group these into 3 categories. The first is something most patients want to know, and that's how do I manage the stoma, how do I manage the pouch during sex? The second is, well, what if I do have problems post-op? What if I can't get an erection? Then what can we do? What options do we have? What's out there? What treatment is available? And finally, for people who are single, they're going to have questions about when and how to tell. So we're going to go through each of these briefly. Now, you will have the opportunity to discuss this further when you come on site for Bridge Week, just to let you know. So managing the stoma and pouch during sexual activity. We have a couple of goals. One, we want to minimize the risk that they will have leakage. And 2, we want to help shift the focus away from the stoma and pouch and back to their partner and to sharing. So we tell them, first of all, always empty your pouch before sexual activity. So if your partner comes towards you with that look in their eyes, say, hold that thought and go empty your pouch. You don't want to begin sex with a full pouch. Markedly increases the risk of leakage. Secondly, you want to make sure the pouch is not flapping. So you want to secure and conceal the pouch. Well, you want to secure the pouch. And most patients and partners elect to conceal the pouch, at least initially. So let's look at options. You have specific options listed on your handout and here. In terms of securing, you could do something as simple as taping the pouch down. If you have a patient with a low output stoma, like a colostomy, and if they're wearing a two-piece system, they could snap off their regular pouch and snap on the closed-end mini pouch that's much shorter and it's not going to flap. In contrast, if they have a high output ileostomy, that's not a good choice unless they're planning a quickie and all systems are go, because one of those little mini pouches has very little capacity. Most patients elect an option that both secures and conceals. And that can be a variety of things. You're going to see some options when you come on site. Some of you have seen some of these. You can go online. One of the most widely used is Ostomy Secrets. And it's patterned after Victoria's Secrets. And they have underwear for routine use, but they also have abdominal little, what's the right term? It's almost like a mini binder. And it just pulls down over the abdomen and secures the pouch and covers up the pouch and the stoma. For women, they have one that's black and it's shirred, and it's got just enough spandex in it to hold it very securely and very flat against the abdomen. For men, they have a beige wrap. You can see on your hard copy, there's also a company that makes something called Options Underwear that has snap-out crotches. There's also Intimate Moments apparel, Yental Secrets, so there's a number of options. So you can go to Ostomy Underwear and see all the different options. Patients can make their own. I had a patient who made a black silk cummerbund that just fastened with Velcro, because she said she and her husband both liked black silk. And so I have to tell you a cute story. She was in the hospital for a procedure, and I went to talk to her husband while she was in surgery. And he said, Dorothy, did Pat ever tell you about that black silk cummerbund she made? And I'm like, yeah, she did tell me about it. He's like, yeah. He's like, you know what's really good about that thing? And I'm like, well, I know some things that are good, but you tell me what you think is particularly good about it. He's like, when she puts that on, I know exactly what she's got in mind, and I just get ready. I'm like, see, that's the ultimate in nonverbal communication. So it could be a commercial product. It could be a self-made product. It could be something as simple as one of those little tube tops that you can buy in almost any store very inexpensively. All you need is something that pulls down, conceals and secures the pouch, conceals the stoma, and leaves all the good spots free. So whatever works for that patient and his or her partner, well, that's what it's all about. They can brainstorm together. The second category of specific suggestions is, well, what's out there for us if I can't get an erection post-op and we want to be able to have sex? Well, first of all, you want to remind the patient and the partner that there's more to sex than intercourse, that there's many, many ways to give and share sexual pleasure. They could use vibrators, they could use oral stimulation, they could use manual stimulation. Most patients have already thought of that. But if they're asking you specifically about what their options are for being able to have intercourse, that's because they want to have intercourse. For many patients and their partners, that's their preferred approach to giving and receiving sexual pleasure. So on your handout, and you don't have to know any of this in detail, you just need to know what's out there for these patients, and then you can always go online or come to your module to get specific information should you need it. But I want to go over just what is out there. First of all, what about all those oral medications? Will they help patients who have sexual dysfunction caused by nerve damage? And the answer is, usually they do not help. So let me explain how they work. We've already said it's parasympathetic stimulation that causes vasodilation. This is how it works. With parasympathetic stimulation, you produce acetylcholine. Acetylcholine undergoes a number of chemical reactions, and the end result is nitric oxide, which is a powerful vasodilator. So you're producing nitric oxide in increasing amounts during sexual arousal. Now, normally, nitric oxide is very short-acting because it's rapidly inactivated by enzymes present in the tissues. With normal function, that's not a problem because with increasing arousal, you're getting more and more acetylcholine, more and more nitric oxide. So the fact that the first responders are now missing in action is no problem because I have all these other nitric oxide molecules that are taking over. What those medications do, Viagra, Cialis, Levitra, what they do is they block the effect of the enzymes that normally inactivate nitric oxide. So that means every little bit of nitric oxide that's produced hangs around longer and contributes more to vasodilation. So let's say that surgery damaged 40 to 50% of my nerve pathways. 50 to 60% are still intact. And I'm getting very weak erections, but not enough for intercourse. Might these medications work? Absolutely, because what are they going to do? They're going to strengthen my erection by potentiating every bit of nitric oxide that's produced. Worth a try. In contrast, if 80% of my nerve pathways were destroyed, those oral medications are not going to work. A lot of surgeons will say, I don't know how much nerve damage was sustained. Let's start with the oral medications and see if they work. And then you say to the patient, we'll start here. That doesn't work, not a problem. We have other strategies. Next strategy is urethral suppository, very slender suppositories that the patient inserts into the urethra. I know it makes me wince too. But then the medication is absorbed through the urethral wall into the erectile tissue, and the medication is a vasodilator. Now, this is pretty effective. It comes also with a little lariat-type device that the patient applies at the base of the penis to enhance and maintain the erection. Some patients get very good results, and other patients are like, I can't stand it. It causes too much urethral irritation and burning and pain. I can't stand it. Okay, some patients that works, other patients it doesn't. Next option, penile injection therapy. Whoa, that sounds awful, but actually it's given high on the shaft with a very, very thin needle, and most men report minimal discomfort. Plus they've told me, no pain, no gain, I can handle that. But you want them to know, no, this is not a big painful shot, because most men do not want to give their penises a big painful shot. It's a very, very small needle, so minor discomfort. But the advantage of the injection is you're injecting a vasodilator directly into the erectile tissue. Now, it's usually the urologist and possibly a urology NP or PA who works with the patient and the partner to determine the optimal dose. So they literally bring them in. They start with a low dose. If that works, great. They teach them how to do it and they send them home. Low dose does nothing. Okay? They titrate the dose up. Does that work? If so, instruct, go home. Nope. Titrate up until you get to an effective dose, then teach the patient and partner and send them home. What else is out there? Vacuum therapy. Very simple device. I should have brought one in to show you, but I didn't. You can see one when you're on site. You can ask to see one. Vacuum therapy is very simple. You just put a plastic cylinder around the penis, and so the base of the cylinder is against the lower abdomen, and it's attached to a pump device, and you just activate the pump device, and the negative pressure pulls blood into the erectile tissue. Then there's a little retention ring at the base of the cylinder, so when I remove the cylinder, I pull the little retention ring off so that it fits around the base of the penis, retains blood in the penis. It's designed, you get an erection very quickly, within just a couple of minutes, and then they tell patients, don't leave that ring on longer than 30 to 45 minutes because you don't want to get bruising petechia. And then the last option, well, let me just back up and tell you one thing about vacuum therapy. Medicare will pay for it. It's relatively low cost. You can get it, through your urologist. It comes with a little kit that has everything you need and a DVD that provides instructions. Also, it's non-surgical, so it's well tolerated, reversible. It's a very good choice for short-term use anyway. And some centers that are encouraging patients post-cystoprostatectomy to initiate erections during those first 6 months, they prescribe vacuum therapy. And then the last thing is surgery, penile prosthesis. So you can always do a surgical procedure to insert rods into the penis. You can insert semi-rigid rods. That's not done very often. More commonly, what they insert is a little cylinder that can be inflated. And so it's a fairly complex device. You have these cylinders, twin cylinders inserted into the erectile tissue, connected to tubing, and that tubing connects to a reservoir that's placed in the lower abdomen and to a control device that's placed in the scrotum. So the advantage is you can pump it up when you want an erection and you deflate it when you're through, so that it's very physiologic. So the patient they bring the patient back, do the surgical procedure, implant the inflatable rods, implant the reservoir, implant the control device. Let everything heal, so no sex, no using the device for 6 weeks until a nice sleeve of granulation tissue forms around the device. Then bring them back, teach them how to use the pump to activate the device when they pump the little device in the scrotum. It diverts fluid from the reservoir into those inflatable rods, and you get an erection. When you're through, you deflate and it goes down. So one of my patients was like, wait, I want to be sure I'm clear on this. So when you want to have sex, you just pump it up? I'm like, right. And it stays up until you pump it down? Right. Wait till I tell the guys. So that's the other option. We use penile prostheses extensively when we were doing standard cystoprostatectomies and patients had no potential for return of erectile function. They're used less commonly now. One of the negatives to the penile prostheses is that once you do that, you're going to get scar tissue that forms around those rods. That's going to destroy the natural erectile tissue. So once you go the surgical route, you can't back up. So it's usually considered last resort therapy, but quite effective for most patients. What about if you have a female partner who's unable to have intercourse, maybe for a period of time until her partial vaginectomy suture line heals, or until her vaginal reconstruction heals? What options do she and her partner have? Well, the same things: manual stimulation, oral stimulation, vibrator stimulation. But remember that a lot of these patients are older. They might not be comfortable with other forms of sexual expression. They might be more comfortable with what we call simulated intercourse. And simulated intercourse is basically penile thrusting between lubricated body folds. So actually, any body folds will work, for the male especially. But the best option for both male and female is penile thrusting between the thighs. Because if you do penile thrusting between the thighs, that gives stimulation to the penile shaft for the male, and it gives clitoral stimulation for the female. So that's what we usually recommend. I remember talking to one lady about this, and she's like, oh, that's so good to know, because my husband and I really enjoy sex, and we were worried that we wouldn't be able to have sex for months until this suture line healed. And I like that idea of that thrusting bit, because she's like, look at me, I am a target-rich environment. I have folds everywhere. I've got big boobs, I've got body folds. So she came back and she's like, yeah, we kind of worked our way around, but when he was thrusting between my breasts, it felt pretty good to him, but I was looking at his belly button. It wasn't doing anything for me. So she's like, yes, between the thighs, that's the best. Tell the others. What about gay and lesbian couples? Well, they have the same needs, same concerns as straight couples. They're concerned about how their partner is going to react. They want to know about their ability to provide pleasure to their partner. Now, there's a couple of things that you need to know in working with gay and lesbian patients. First of all, they know that a lot of people are not open to homosexual practices. And so they might be very reluctant to ask questions, especially if you use gender-specific terms that kind of eliminate homosexual behavior as an option. For example, if I'm talking to a female and I always talk about her partner as him, have you talked to your partner? How is he doing? What does he say? What are his feelings? Well, that doesn't convey any openness to the possibility that she might have a female partner. Same thing if I'm talking to a male and I'm always talking she. Well, what if my partner is a he? Are you able to hear that? Are you able to deal with that? Are you able to answer my questions? So one recommendation is, if you are unsure of your patient's sexual orientation, you don't know if they're gay or straight, use neutral terms. Just say your partner and say, what kind of questions do you have? Sometimes, of course, it's obvious. If I come in with my partner and my partner's female, then obviously I'm comfortable, my partner's comfortable, and we can talk openly. If I come in with my partner and my partner's male, obviously I'm straight, and that takes you down another pathway. But when it's unclear, use neutral terms. Think about the male patient who requires a wide AP resection for rectal cancer. I think that patient is one of the saddest to me, because he's at risk for losing erectile function and the ability to be the active partner. And if he and his partner practice anal sex, he's lost the anal opening, so he can't be the receptive partner. Not all gay men practice anal sex, but of course a lot of them do. And some straight couples practice anal sex as well. So bottom line, I want to use neutral terms. I do want to say to patients, if I have any reason to think that they might be bisexual or gay, I should just say something like, one thing we tell all of our patients is not to put anything in the stoma because they can cause damage, and not to use the stoma for sex. Because some people wonder, people have anal sex, can you use the stoma for sex? But no, the stoma is different than the anus and the anal canal. If you use it for sex, you're going to stretch a ring inside that's very tight. That can cause bleeding and scarring, and it can cause major problems down the road. So we just tell everybody, don't put anything in your stoma, don't use the stoma for sex. Okay. Now, the last area that I wanted to cover under specific suggestions is tips on when and how to tell a potential partner about your ostomy. Now, when to tell is very individual. Some people disclose private information very early in a relationship, and others are much more private and they wait until much later in the relationship. So that's really up to the person. I will tell you this, I have some friends with ostomies and they've told me, you know, I started out not telling people until kind of down the road. And then I decided, you know what, if they can't handle me having an ostomy, I'd rather know now, because I don't want to waste any time on them. So now I use it as a screen for jerks. That's what one of my friends told me. I use it as a screen for jerks. I tell people, you know, once it's clear that we're interested in each other and we're planning to continue this relationship, I bring it up and I say, you know, there's something I need to tell you. There's nothing wrong with me, but I just need to tell you this one thing. And, you know, she said, if they can't handle it, they can just walk out the door, don't let it hit them in the butt on the way out. I'm done. So individual, I cannot make that decision for a person. How to tell, I can give very specific suggestions. And how to tell is practice what you're going to say because you're probably going to be nervous. Be upbeat and be positive. I'm going to give you a couple of demos in just a minute. And one thing I've learned from my patients is tell your patient don't use medical terms. I'll tell you a little bit about that as well. So you can imagine if I come across positive and if I say, hey, there's something I want to tell you about me that's a little bit different, there's nothing wrong with me, there's nothing wrong with my ability to have sex, but I was really sick a few years ago with something called Crohn's disease. I don't know if you know what that is, but it involves the intestine, the bowel. And I ended up having to have a lot of my bowel resected, and as a result, I have an ileostomy. I don't know if you know what that is, but it means that I have a little opening on the side of my abdomen, and that's actually where my poop comes out. And I just wear an odor-proof pouch to collect it. And you've probably not smelled anything because my pouch is odor-proof, and I hope you haven't seen anything because it's pretty flat. But if we keep going down this road, you're going to encounter it, and I wanted you to know what it was. In contrast, what if I say, there's something I have to tell you, and I don't know, it might mean this is the last time I ever see you, but still I know you have a right to know it, and I promised myself I'm gonna tell you tonight no matter what, and if it's the last time I see you, it's the last time I see you. But I've got to do this. Well, gosh, I have set you up to think something terrible. Like what? You know, you violated your parole, you're headed back to prison, you know, you killed your last boyfriend, or what is it that's so terrible? So you want to be upbeat. Now, the thing about not using medical terms, one of my former patients had called me and she's like, okay, dating this guy, we've been going together a good while, I think we're moving to the next level, I need to tell you about this, let's go through, you know, what can you share with me? So I went through, be positive, be upbeat, practice what you're going to say, blah, blah, blah. So she calls me back and she's like, you know what you didn't tell me? You didn't tell me not to use medical terms. You're right. She happened to be an x-ray technologist, so she was very familiar with medical terms. So here's what she told her partner, or her date. There's something I have to tell you about me. There's nothing wrong with me, but I was really sick. I had really severe ulcerative colitis, and then I had megacolon, and I had to have an emergency proctocolectomy and an ileostomy. And so I wear a pouch, but other than that, I'm fine. And she said he looked at her and he said, the last thing I understood was when you said you were really sick. I don't know what any of that stuff means. So she's like, then I'm really flustered. I'm trying to backtrack and use non-medical terms, but I'm really rattled, and so I can't think what to say. And he stops me. He's like, what, does this mean you can't do it? And she's like, oh, no, there's nothing wrong with any of that. And he's like, oh, well, then I don't care. Whatever it is, I'll figure it out. We'll work it out, but I'm not worried. And she's like, sure enough, he didn't care. But Remind people not to use medical terms. So be upbeat, be prepared, practice what you're going to say, and don't use medical terms. Those are your guidelines. The other thing I think is helpful is when a person gets ready to tell another person, you want to walk them through worst case scenario, especially if this is the first time they've done this. So, okay, let's say you never hear from him again. What does that say about you? Well, it doesn't really say anything about me, does it? No, that's the right answer. What does it say about him? He couldn't handle it? Okay, that's the nicest thing we can say about him, so we'll leave it at that. Yes. Bottom line, if you are prepared for worst case scenario, you're prepared for anything else. So I always ask my patients, if telling this person about your ostomy means the end of the relationship, are you ready? And if they say, yes, why would I waste any more time? Then I say, go for it, you're ready. Okay, intensive therapy means you refer the patient to a relationship counselor, a sex therapist, whatever they call them in your area. Those are patients with long-standing problems, a lot of complex issues. If they say, oh, I can't believe I might have trouble with sex, that is such a difficult area in our relationship already. I'm going to give this patient information and support, but I'm going to refer them because this is already an area of conflict. I'm not prepared to deal with that. Now, I wanted to mention the last thing on your handout is that most people don't bring up issues or are not so concerned about sex in the first few weeks post-op. There's always exceptions to every rule, but most people early post-op are more concerned about pain control, being able to empty their pouch without making a mess, getting a pouch to stick, that kind of thing. So typically these issues come up about 4 to 12 weeks post-op. Yet another reason for arranging outpatient follow-up, so you're there to answer these questions. And finally, in your online and hard copy materials, you have some resources you can use. The United Ostomy Association of America has a wonderful booklet entitled Intimacy, Sexuality, and an Ostomy Guide. Great choice. Okay, thank you very much.